Welcome back to the deep dive. If you've ever experienced that sudden, just overwhelming sense of dread, the one that makes your heart race,
Tachycardia, yeah.
right, tachycardia makes your hands clammy, muscles trembling, that feeling, that's anxiety.
Mm-hmm. It's an unpleasant state, that tension and apprehension.
But fundamentally, those physical symptoms,
Yeah.
they're just your sympathetic nervous system, your fight or flight, firing off a full-scale fear reaction.
Even when there's no actual lion in the room, so to speak.
Exactly.
And that fight or flight energy just completely misplaced sometimes and incredibly disruptive. For advanced practitioners, for you listening and aiming for mastery, understanding how we manage that state pharmacologically, well, it's crucial.
And managing the insomnia that often tags along too.
Absolutely. So today we're doing a real deep dive. Think of this as a high-stakes clinical review of these agents, the anxiolytics and the hypnotics.
We're not just summarizing here.
No, definitely not. The goal is absolute mastery. Getting into the complex classifications, those minute mechanistic differences, and the really critical clinical trade-offs. That's what separates, adequate treatment from truly optimal professional practice.
So our mission is comprehensive. We're dissecting two related groups: anxiolytics, for relieving anxiety,
and hypnotics, for inducing sleep.
Right. And there's a huge overlap, of course. Many drugs do both, depending on the dose.
But modern medicine, well, it's driving towards more specific options, cleaner side effect profiles. We need to be highly selective now.
Okay, let's unpack this. Maybe start with a little historical context, because things have really changed.
Yeah.
For decades, anxiety, insomnia, they were treated with agents like barbiturates and meprobamate.
That's right. But the game really changed when benzodiazepines, BZDs, came onto the scene.
H shift.
Huge. They rapidly pushed out those older agents because, well, in a direct comparison, they were generally considered much safer.
Safer and more effective, too.
Generally, yes, especially regarding the lethality of an overdose. That was a major factor.
Safer is the key word there, I think, but it's only relative safety compared to those older drugs.
Exactly. That's a critical point for anyone aiming for mastery here. BZDs, they're certainly not the end-all, be-all solution.
Right. We know now, especially for chronic anxiety, dependence issues, cognitive side effects, it means modern practice often favors SSRIs, maybe SNRIs, or those specific non-BZD hypnotics instead.
Definitely. So we need to spend real time understanding the molecular architecture, the why behind those shifts, and why alternatives are often preferred today. Okay, so to really get BZDs, we have to start at the foundation of how the brain calms itself down. And that means talking about GABA.
Gamma-aminobutyric acid.
Right, GABA. It is the major inhibitory neurotransmitter in the central nervous system, period. If you want to quiet things down in the brain, you need to boost GABAergic transmission somehow.
And BZDs work by targeting the GABA receptor specifically. But these aren't just simple docking ports, are they? They're complex structures.
Incredibly complex. Think of the GABA receptor as this intricate machine. It's made up of 5 subunits, typically some combination of alpha, beta, and gamma types, and these 5 pieces come together to form the receptor complex, which spans the postsynaptic membrane.
And right in the middle, there's a channel.
Exactly, a central ion channel. When GABA itself binds to its specific site on this receptor complex, it causes a conformational change. Basically, it forces that central channel to open up.
And that's where the inhibition happens, because opening that channel lets chloride ions flow in.
Precisely. Negatively charged chloride ions rush from outside the neuron to the inside.
So more negative charge inside the neuron.
Which hyperpolarizes it. It drives the neuron's membrane potential further away from the threshold it needs to reach to fire an action potential. Makes it significantly harder for that neuron to get excited and send a signal.
Resulting in that calming inhibitory effect.
That's the core GABA action.
Okay, now here's the really crucial bit for BZDs, the part that distinguishes them from, say, the barbiturates we'll discuss later. The BZD binding site isn't the same place GABA binds.
Absolutely not. It's a completely separate, distinct, high-affinity allosteric binding site. It's located right at the interface where the alpha and gamma subunits meet.
Allosteric, meaning it influences the receptor's function without directly activating it in the way GABA does.
Exactly. BZDs are modulators. They only work if GABA is actually present and binding. They can't open the channel by themselves.
So what do they do then?
What they do is act as positive allosteric modulators. When a BZD binds to its site, it makes the receptor more sensitive to GABA. Specifically, it increases the frequency of the channel openings produced by GABA.
Frequency, not duration.
Frequency, that's the key distinction. GABA is still the one opening the door. The BZD just makes it open the door more often when GABA binds. It enhances the natural inhibitory signal that's already there.
Okay, and that mechanism, the frequency modulation, is why they're relatively safer than barbiturates.
Precisely. Think about it. GABA has to be present, and the BZD just makes GABA work more efficiently. It's a controlled enhancement. This is a major reason for their much wider safety margin.
I remember seeing a figure 9.2 in our source material, comparing diazepam and phenobarbital. The lethal dose for diazepam was something like over 1,000 times the therapeutic dose.
That's right, over a 1,000-fold difference. Compare that huge therapeutic index to phenobarbital, a barbiturate, and you immediately grasp why BZDs replace them. They're just not easily lethal in overdose. Unless they're combined with other CNS depressants like alcohol or opioids. That's a different and very dangerous story we'll definitely get back to. #tag due to be. The 5 principal actions and subunit specificity.
Okay, so BZDs get into the brain easily because they're lipophilic.
Very much so.
And they produce 5 main effects, all stemming from enhancing GABA. But for mastery, you said we needed to link these effects to specific subunits of the GABA receptor in different brain areas.
Yes, this is where it gets really interesting and explains why different BZDs might have subtly different profiles and why designing new drugs is so complex. Let's break down the 5 actions.
Okay.
Action number 1, reduction of anxiety, the anxiolytic effect. This happens at relatively low doses.
Where in the brain is this happening?
It's thought to be mainly mediated by enhancing GABA's effects in neuronal circuits within the limbic system, the emotional processing center of the brain. And importantly, this seems to involve GABA receptors that contain the alpha-2 subunit.
Wait, alpha-2? I thought alpha-1. Alpha-1 was the main one for BZD actions.
Ah, that's a common point of confusion, but a critical one for mastery. Alpha-1 is heavily involved in sedation, hypnosis, and amnesia, as we'll see. But the specific anxiolytic effect, the anxiety reduction itself, appears to be primarily linked to the alpha-2 subunits, particularly in those limbic areas.
Okay, that distinction is huge. It suggests you could theoretically target alpha-2 for anxiety without causing sedation if you could avoid alpha-1.
That's exactly the goal of much modern drug design research. Okay, action 2. Set a hypnotic action.
Making you drowsy or putting you to sleep.
Right. This occurs at higher doses than required for anxiety relief. And this affects the sedation and the ability to induce sleep. The hypnotic effect is mediated primarily by those GABA receptors containing the alpha-1 alpha-dollar subunit.
Okay, so alpha-dollars is key for sedation. What's next?
Action 3, which is clinically very useful, anterograde amnesia.
Meaning you can't form new memories while the drug is active,
Yeah.
like for procedures.
Exactly. It's a temporary impairment of memory consolidation. Think conscious sedation for an endoscopy. The patient is calm, cooperative, but won't remember the unpleasantness later. This effect is also strongly mediated by the alpha-1 alpha-dollar subunit. Midazolam's utility relies heavily on this.
Makes sense. Action 4.
Anticonvulsant action, their ability to stop seizures.
Also alpha-dollar.
It seems to be partially mediated by alpha-1 alpha-dollars containing GABA receptors, yes. Which makes sense given its role in general CNS depression. This is why drugs like diazepam or lorazepam are first line for status epilepticus.
Okay, and the last one. Action 5.
Muscle relaxant action. This generally requires higher doses. It helps reduce skeletal muscle spasms and spasticity.
Which subunit is involved here? Back to alpha-1.
Actually, evidence suggests this effect is primarily driven by actions at GABA receptors containing the alpha-2 subunit, particularly through increasing presynaptic inhibition in the spinal cord.
So alpha-2 again, like the anxiolytic effect. Interesting, it's not just one subunit doing everything.
Not at all. And just as a side note for context, this muscle relaxant effect via GABA in the spinal cord is distinct from how other muscle relaxants like baclofen work, which targets GABA receptors.
Okay, let me try to synthesize this then.
Yeah.
Alpha-1 seems responsible for the more immediate, sometimes problematic effects. Sedation, hypnosis, amnesia, and probably contributes significantly to the dependence potential.
That's a good summary.
Whereas alpha-2 seems key for the desired therapeutic effects in anxiety and muscle relaxation.
Largely, yes. Though there's overlap and complexity, that's the general picture emerging.
So the ideal anxiolytic, theoretically, would hit alpha-2 too hard, and maybe alpha-3 or alpha-5-Is, which we haven't discussed much, but also exist while completely avoiding alpha-2-1.
That's the holy grail. Selectivity is everything. Designing a drug that provides anxiety relief without sedation, amnesia, or dependence, that's the challenge. And it hinges on understanding this subunit pharmacology. So, knowing these actions and the subunit links helps us understand the clinical applications. The choice of which BZD to use really comes down to balancing these effects against the patient's specific needs and, crucially, the drug's duration of action.
Right. Let's start with anxiety disorders. BZDs are incredibly effective for acute situations, aren't they?
Absolutely. For things like panic disorder, generalized anxiety disorder, GAD, when it flares up severely, social anxiety disorder in specific triggering situations, or phobias like fear of flying, they provide almost immediate relief.
But there's always a but with BZDs.
Always. Because of the significant potential for addiction and dependence, they really should be reserved for severe, debilitating anxiety and ideally used only short-term, weeks, not months or years, unless absolutely necessary and carefully managed.
And the duration matters here, too. For ongoing anxiety, longer-acting ones might be better.
Often, yes. For managing anxiety over a longer period, agents like clonazepam, lorazepam, or diazepam are frequently preferred. Their longer half-lives mean smoother coverage and, importantly, a less abrupt withdrawal if they need to be tapered off.
What about alprazolam? That one comes up a lot for panic disorder.
It does. Alprazolam is highly effective. Some consider it almost specific for panic disorder, but it carries a major warning flag. It's short-acting and quite potent. This combination leads to a notably high risk of dependence and severe withdrawal symptoms upon discontinuation. Some estimates suggest up to 30% of long-term users experience significant withdrawal.
That's a huge risk-benefit calculation for the clinician and the patient.
It really is. Okay, let's shift to sleep disorders or insomnia.
BZDs work well as hypnotics, getting people to sleep.
They do. They decrease sleep latency, the time it takes to fall asleep, and they increase the amount of stage 2 non-REM sleep.
But they mess with sleep architecture, right?
That's the downside. They significantly decrease both REM sleep and slow-wave sleep, deep sleep. This can leave people feeling less rested even if they slept longer. And again, dependence is a major concern. The general consensus is clear. If you're using a BZD for insomnia, it should be short-term only, 1 to 3 weeks max.
And again, duration dictates the choice. Short-acting 4.
Short-acting agents like triazolam, these are really only suitable for people who have trouble falling asleep. Its very rapid elimination means less daytime grogginess, which is good. But just like alprazolam, that short half-life means a higher risk of withdrawal effects, especially rebound insomnia, where the insomnia comes back even worse when the drug is stopped.
Okay, what about intermediate-acting ones?
Temazepam is the classic example here. It's useful for people who can fall asleep okay but have trouble staying asleep, those who wake up frequently during the night.
And you need to time the dose correctly.
Yes, because it's intermediate acting, you actually want to administer it about 1 to 2 hours before the desired bedtime. This allows time for absorption, so it reaches peak effect when the patient actually wants to be asleep and stay asleep.
Makes sense. And the long-acting ones, like flurazepam, are they used much for sleep?
Very rarely nowadays for insomnia, and for good reason. Their very long half-lives lead to drug accumulation in the body, which means a significant risk of excessive daytime sedation, cognitive impairment, hangover effects. This is particularly dangerous in the elderly, where it increases the risk of falls and confusion. Flurazepam, for instance, should almost always be avoided in older adults for sleep.
Okay, we mentioned the cognitive effects. Let's talk about using amnesia for conscious sedation.
Yes, that anterograde amnesia mediated by alpha-1 is leveraged therapeutically. Short-acting agents, especially midazolam, are invaluable.
How so?
They're used as premedication before procedures that are known to be anxiety-provoking or uncomfortable. Think endoscopies, colonoscopies, dental surgery, cardioversions, setting fractures. The patient remains conscious or lightly sedated, conscious sedation, able to respond to instructions.
But they don't remember the unpleasantness afterwards.
Exactly. It's a huge benefit for patient comfort and tolerance of necessary procedures.
And then there are the critical care uses, seizures and alcohol withdrawal.
Life-saving applications here. Intravenous lorazepam or diazepam are the drugs of choice for terminating status epilepticus, continuous seizure activity.
And alcohol withdrawal. Why BZDs?
Because of cross-tolerance. Alcohol works in part by enhancing GABAergic inhibition, similar to BZDs. When someone who is physically dependent on alcohol stops drinking abruptly, their brain is suddenly in a hyperexcitable state. BZDs can substitute for the alcohol at the GABA receptor, calming the system down.
Preventing seizures and delirium tremens?
Precisely. Agents like chlordiazepoxide, which is actually the first BZD, diazepam and lorazepam are mainstays in managing acute alcohol withdrawal, significantly reducing the risk of potentially fatal seizures.
The more use. Muscular disorders.
Right. Diazepam, in particular, is widely used for its muscle-relaxing properties, remember, linked to alpha-2 subunits in the spinal cord. It provides relief from skeletal muscle spasms caused by various injuries or inflammation, and also helps manage spasticity associated with chronic neurological conditions like multiple sclerosis or cerebral palsy. #HAGB, pharmacokinetics, fate and half-life.
Okay, we've covered what they do and why we use them. Let's talk about how the body handles them. Pharmacokinetics. You mentioned they're lipophilic.
Highly lipophilic, which means they are absorbed very rapidly and completely after you take them orally. They distribute quickly throughout the body, easily crossing the blood-brain barrier to get into the CNS where they act.
But metabolism is where it gets complicated, right?
Sure.
Especially with the half-life.
This is the key pharmacokinetic complexity you absolutely have to grasp for safe prescribing. Most BZDs, including major ones like diazepam and chlordiazepoxide, are metabolized by the liver, specifically the cytochrome P450 microsomal enzyme system.
Okay, standard liver metabolism. What's the complication?
The complication is that the liver doesn't just inactivate them, it often metabolizes them into other compounds that are also pharmacologically active.
Wow. So the drug keeps working even after the original molecule is broken down.
Exactly. These active metabolites can have half-lives of their own, sometimes even longer than the parent drug. This dramatically extends the overall duration of action.
So the half-life listed in a textbook might not tell the whole story.
It often doesn't reflect the clinical duration of effect accurately. That reported half-life might represent the parent drug, but the patient is still experiencing effects from the active metabolites accumulating. This combined action can push the functional half-life out significantly, sometimes well beyond 24 hours, especially with drugs like diazepam.
Which really matters for dosing intervals and avoiding accumulation, especially in elderly patients or those with liver problems.
Absolutely critical. Eventually, the parent drug and its metabolites are further processed, usually conjugated with glucuronic acid, and then excreted by the kidneys in the urine. But you must consider the contribution of active metabolites when choosing a BZD and determining dosing. Knowing whether you're dealing with a truly short-acting agent like midazolam or lorazepam, which has no active metabolites, an intermediate one, or a long-acting one with active metabolites like diazepam is essential.
And a critical safety point for specific populations.
Yes. All BZDs cross the placental barrier. They can enter the fetal circulation and potentially depress the newborn's CNS. There's a risk of floppy infant syndrome if used near term.
So generally not recommended during pregnancy.
Definitely not recommended, especially in the first trimester and near term. They are also excreted in breast milk, so they're generally contraindicated during nursing as well.
Okay, we have to really confront the major downside now. Despite their relative safety in acute overdose compared to barbiturates, chronic BZD use carries serious risks. Dependence.
Yes. Psychological and physical dependence are significant problems. They can develop quite quickly, especially if higher doses are used for prolonged periods, think longer than a few weeks.
Which is why they're controlled substances.
Exactly. And abrupt discontinuation or even too rapid tapering in someone who has become dependent can trigger a really unpleasant and potentially dangerous withdrawal syndrome.
What does that look like?
It can range from increased anxiety, insomnia, restlessness, and agitation to more severe symptoms like confusion, tension, and in rare but serious cases, generalized seizures.
Now, you mentioned earlier that the half-life plays a counterintuitive role here, the half-life paradox.
Yeah.
I think figure 9.5 in our material highlights this. It's not what you'd initially expect.
It really isn't, and this is a crucial point for clinical practice and for mastery. You might think longer-acting drugs would cause worse withdrawal, but it's the opposite.
So the shorter-acting ones are worse for withdrawal?
Yes. Drugs that are more potent and critically more rapidly eliminated triazolone is the classic example, cause much more abrupt and severe withdrawal symptoms, including rebound insomnia.
Why is that?
Because the drug basically disappears from the receptor site very quickly. The body's GABA system, which has adapted to the drug's presence, doesn't have time to readjust gradually. It's like pulling a rug out from under it, instant physiological shock.
Whereas the longer-acting drugs?
The less potent, slowly eliminated drugs like flurazepam or diazepam with their long-acting metabolites essentially perform their own slow, gradual taper as they clear from the body over days or even weeks.
So the withdrawal is less intense, less abrupt?
Exactly. It gives the brain more time to adapt back towards its baseline state. The slow clearance, while causing potential daytime sedation during treatment, can actually be a benefit when it comes time to discontinue the drug, making the process smoother and less distressing for the patient. It's a key trade-off to consider. #B, adverse effects and interactions. Beyond dependence and withdrawal, what are the most common side effects people experience while taking BZDs?
Primarily cognitive, right? Drowsiness and confusion seem to top the list.
They do, and at higher doses, you can see ataxia.
Loss of coordination.
Right, which makes activities like driving or operating machinery dangerous. This is a really important counseling point.
And that cognitive impairment isn't just drowsiness, it's also linked back to that alpha-1 mediated amnesia we discussed.
Yep.
Decreased ability to learn and retain new information in daily life.
Yes, that can be a significant issue, especially with long-term use or in older adults. We also need to be cautious using them in patients with significant liver disease, since the liver is crucial for metabolism.
But the most dangerous interaction is combining them with other things that slow down the brain.
Absolutely. Synergistic CNS depression, alcohol's the big one, but also opioids, barbiturates, even some antihistamines. Combining these with BZDs dramatically enhances the sedative and hypnotic effects.
And this is where the relative safety of BZDs breaks down completely.
Completely. We said BZD overdose is seldom lethal on its own, but that relatively high therapeutic index just vanishes when they're combined with alcohol or opioids. That combination is tragically common and accounts for a huge number of fatal overdoses.
Okay, so if someone does overdose on a BZD, or if we need to rapidly reverse the sedation after a procedure where midazolam was used, there's an antidote, right?
Flumazenil.
Yes. What's its mechanism? How does it work?
Flumazenil is a specific GABA receptor antagonist. It works by competitively binding to that same allosteric BZD binding site on the GABA receptor complex.
So it basically kicks the BZD off the receptor or prevents it from binding.
Exactly. It blocks the BZD's ability to enhance GABA's effects, thereby reversing the sedation, respiratory depression, and other BZD-induced effects. It's given intravenously and works very quickly.
But I remember reading its duration is really short. That seems like a practical problem.
It's a major challenge. Flumazenil has a very short half-life, only about an hour.
So if you used it to reverse a long-acting BZD like diazepam,
You'd have a problem. The diazepam and its active metabolites would still be hanging around in the body long after the flumazenil wears off. The patient could become resedated. So you often need to give repeated doses of flumazenil, sometimes even a continuous infusion, and monitor the patient very closely until the BZD has cleared sufficiently.
and using the reversal agent itself isn't without risks, especially in certain situations.
Definitely not. Giving flumazenil to someone who is physically dependent on BZDs can precipitate an immediate severe withdrawal syndrome, including seizures.
That makes sense. What else?
If the patient was taking the BZD to control an underlying seizure disorder, obviously reversing the BZD with flumazenil could trigger status epilepticus.
Right.
And perhaps most dangerously, in cases of mixed overdoses, if the patient took BZDs along with other drugs like tricyclic antidepressants or certain antipsychotics, which can lower the seizure threshold themselves, giving flumazenil can actually unmask the proconvulsant effect of those other drugs and potentially induce seizures, even if the BZD wasn't the primary problem initially.
So it sounds like you need to be pretty sure it's primarily a BZD issue before using flumazenil.
You really do. It's a powerful tool, but it requires careful consideration of the patient's history, dependencies, and potential co-ingestants.
Okay, given all the risks we've just detailed, dependence, withdrawal, cognitive effects, it's clear why the medical community looked for alternatives, especially for chronic anxiety. Where do things stand now? What's considered first line?
For chronic anxiety management, generalized anxiety disorder, panic disorder, social anxiety disorder, the first-line agents are now overwhelmingly antidepressants.
Not BZDs.
Not for long-term primary management, no. Antidepressants are preferred, particularly where dependence is a concern, which it almost always is with chronic use.
Which classes are we talking about?
Primarily the selective serotonin reuptake inhibitors, the SSRIs, drugs like citalopram, paroxetine, sertraline, and the serotonin norepinephrine reuptake inhibitors, the SNRIs like venlafaxine or duloxetine.
Interesting that drugs developed for depression work so well for anxiety. Why is that?
It reflects our understanding that the underlying neurobiology of chronic anxiety often involves dysregulation in the serotonin and/or norepinephrine pathways, similar in some ways to depression. The mechanism is totally different from BZDs, though.
How so?
BZDs are like a quick fix, directly amplifying GABA inhibition for immediate effect. Antidepressants work much more slowly over weeks. They gradually modulate the serotonin and norepinephrine systems, leading to adaptive changes in the brain that reduce anxiety symptoms over time. It's more about system re-regulation than immediate suppression.
And is one SSRI or SNRI clearly better than others for anxiety?
While some agents have specific FDA approvals for certain anxiety disorders, the general thinking is that the anxiolytic effect is largely a class effect. The choice often comes down to side effect profiles and individual patient response.
But here's the practical issue. Antidepressants take weeks to work rate, 4 to 6 weeks, sometimes longer.
That's the major drawback for acute symptoms.
So what do you do for the patient who needs relief now, but you want to start them on an antidepressant for the long run?
That's where we often use a bridging strategy, like the one shown in figure 9.6 in our sources. You initiate the antidepressant, say an SSRI, for the long-term benefit, but at the same time, you start a short course of a BZD, like lorazepam.
For immediate symptom control.
Exactly. The BZD provides that rapid relief while the antidepressant is slowly starting to kick in. Then, crucially, after those 4 to 6 weeks, once the antidepressant has reached its therapeutic effect, you carefully and gradually taper the BZD off completely.
That requires good patient education and a clear plan.
Absolutely. And it's important for patients to understand that for chronic anxiety, treatment with the antidepressant often needs to be long-term, sometimes a year or even longer, to maintain remission and prevent relapse. #B buspirone, the non-sedating option.
Okay, antidepressants are first line for chronic anxiety.
Yeah.
But what if a patient is particularly concerned about sedation, or the interaction with alcohol, or even the potential, however small, for dependence with SSRIs? Is there another option?
There is. Buspirone is an interesting alternative, specifically for generalized anxiety disorder, or GAD. Its efficacy for GAD is considered comparable to BZDs.
But its mechanism is totally different, right? Not GABA related at all.
Completely different. Buspirone primarily works as a partial agonist at serotonin 5-HT1A receptors. It also has some weaker affinity for dopamine D2 receptors and serotonin 5-HT2A receptors. But the main action is thought to be via 5-HT1A.
And that unique mechanism gives it some key advantages, but also a big disadvantage.
Yeah, exactly. The major disadvantage is its onset of action. Like antidepressants, buspirone works slowly. It takes several weeks of consistent dosing to see the full anxiolytic effect.
So it's absolutely not useful for acute anxiety or panic attacks. Can't take it as needed.
No, definitely not. It's purely for chronic, ongoing management of GAD. That slow onset is its biggest limitation.
Okay, but what about the advantages? I'm looking at figure 9.7 here, comparing it to alprazolam. The profile looks much cleaner for long-term use.
It really is. Buspirone causes minimal, if any, sedation. It doesn't typically cause psychomotor impairment or cognitive dysfunction like BZDs can.
Less fuzziness.
Right, and dependence is considered very unlikely, so it's not a controlled substance. It also lacks the anticonvulsant and muscle relaxant properties of BZDs.
Which could be good or bad depending on the patient's needs.
True, but perhaps the most significant advantage for many patients is that buspirone does not potentiate the CNS depression caused by alcohol.
That's huge from a safety perspective. You don't have that dangerous synergistic effect you worry about with BZDs and alcohol.
Exactly. So for a patient with GAD who needs long-term treatment, can wait for the effect to build, and for whom sedation, cognitive effects, dependence potential, or interaction with alcohol are major concerns, buspirone is a very valuable option.
Now, to really appreciate why BZDs became the standard and why we've moved towards even cleaner agents like SSRIs and buspirone, we need to understand what came before. The barbiturates.
Yes, and understanding their pharmacology is key to understanding why they failed, or rather, why they were largely abandoned for anxiety and sleep. The reasons are overwhelming.
What were the main issues?
They induce tolerance very rapidly. They cause profound physical dependence. They are notoriously lethal in overdose. The therapeutic index is dangerously narrow. And withdrawal from them is severe, potentially even fatal. They're all controlled substances, of course, though rarely used for these indications today.
Let's really zero in on the mechanism again, contrasting it with BZDs. We said BZDs increase the frequency of GABA-mediated chloride channel opening. How do barbiturates work differently at that same GABA receptor?
Barbiturates also enhance GABA's effect, but they do it by prolonging the duration that the chloride channel stays open each time GABA binds.
So instead of more frequent quick openings, it's fewer openings, but each one stays open much longer.
Exactly. Think of it like this. BZDs are tapping the inhibitory brake pedal more often. barbiturates are slamming the brake pedal down and holding it there for longer each time.
Which allows a much greater, more sustained influx of chloride ions.
Precisely. Driving the neuron much further into hyperpolarization, causing a much deeper and less easily controlled level of CNS depression.
And they don't just work through GABA, right?
And that's another key difference. At higher concentrations, barbiturates can also directly block excitatory neurotransmitter receptors, specifically glutamate receptors, like AMPA receptors. This further contributes to their profound depressant effects and their narrow margin of safety. They essentially shut down neuronal activity from multiple angles.
Which leads to that dangerous dose-dependent spectrum of effects.
Yes. With barbiturates, you can achieve essentially any level of CNS depression just by increasing the dose. Low doses cause sedation. A bit higher, you get hypnosis, sleep. Higher still, you get surgical anesthesia, complete loss of sensation and consciousness. And just slightly higher than that, you reach coma, profound respiratory depression, and ultimately death.
That progression is terrifyingly steep compared to BZDs.
Extremely steep. The dose needed for anesthesia isn't that much higher than the dose for hypnosis, and the lethal dose isn't much higher than the anesthetic dose. Very little room for error.
Okay, 2 other points about their actions. First, pain. Do they help with pain?
Absolutely not. This is a counterintuitive but critical fact.
Yeah.
Barbiturates do not raise the pain threshold. They have no analgesic properties whatsoever.
Can they make pain worse?
They can, paradoxically. In the presence of pain, low doses might cause excitement or delirium rather than sedation. They are absolutely not used for pain control, sometimes as a component in old combination headache formulas.
And second, the lethality in overdose is almost always respiratory failure.
Yes. The primary cause of death in barbiturate overdose is respiratory depression. They profoundly suppress the brainstem's respiratory center, specifically blunting the normal response to high carbon dioxide levels, CO2, and low oxygen levels, hypoxia. Basically, they shut down the body's drive to breathe.
Which again highlights why combining them with alcohol, another respiratory depressant, was so incredibly dangerous.
Lethally so. ##B. Clinical uses and adverse effects.
Historically, barbiturates were grouped by how long they acted. Long-acting like phenobarbital, short-acting like pentobarbital or secobarbital. But you said their use as sedatives or hypnotics is basically obsolete now.
Largely rejected, yes. The risks just vastly outweigh the benefits for those indications, especially with safer alternatives available.
So what are they still used for, if anything?
The main remaining niche is for anticonvulsant activity. Phenobarbital, the long-acting one, still has specific and effective anticonvulsant properties. It's used for certain types of seizures, sometimes neonatal seizures, or in cases of refractory status epilepticus when first-line agents fail.
But even there, it's not without problems.
No. Its use is always weighed against the significant risk of cognitive side effects. It can depress cognitive development in children and cause sedation and impaired cognitive performance in adults. Another one, batalbital, is still found in some combination products, usually with caffeine and acetaminophen or aspirin, for tension headaches or migraines.
Okay, let's talk adverse effects more broadly, especially drug interactions. They're famous for messing with liver enzymes, aren't they?
Infamous, really. Barbiturates are potent inducers of the cytochrome P450-CYP450 microsomal enzyme system in the liver.
Inducers, meaning they speed up the metabolism of other drugs.
Dramatically so. Taking a barbiturate chronically ramps up the liver's machinery for breaking down drugs. This means many other medications that are metabolized by the same CYP450 enzymes will be cleared from the body much faster than usual,
leading to lower drug levels and potentially therapeutic failure.
Exactly. This isn't a subtle effect. It can significantly diminish the effectiveness of countless essential medications, everything from warfarin, an anticoagulant, to oral contraceptives, to certain antibiotics and steroids. Managing these drug interactions was a major clinical challenge when barbiturates were widely used.
You also mentioned a specific contraindication.
Yes, they are absolutely contraindicated in patients with acute intermittent porphyria. Barbiturates can trigger severe attacks of this genetic metabolic disorder.
And finally, withdrawal. You said it's potentially fatal.
It is. Withdrawal from chronic barbiturate use is medically serious and much more dangerous than, say, opioid withdrawal. Abrupt cessation can lead to severe tremors, anxiety, insomnia, delirium, hallucinations, cardiovascular instability, and life-threatening tonic-clonic seizures. Can absolutely result in death if not managed properly, often in a hospital setting. Overdose, conversely, presents as shock, coma, and respiratory arrest requiring immediate intensive care.
Okay, so barbiturates were too dangerous. BZDs were better, but still had issues with dependence, withdrawal, and altering sleep architecture. This led pharmacologists to search for even cleaner hypnotics, right? Which brings us to the Z drugs.
Exactly. Zolpidem, zaleplon, and azopiclone. Structurally, they are not benzodiazepines. They look different chemically.
But they still work on the GABA receptor.
They do. That's the key. They bind to the GABA receptor complex, but they do so with a much higher degree of selectivity compared to traditional BZDs. They preferentially bind to GABA receptors that contain the alpha-1 alpha-dollar subunit.
And alpha-1, we established, is the subunit primarily responsible for sedation and hypnosis.
Precisely. So by selectively targeting alpha-1, the Z drugs aim to capture the hypnotic effects of BZDs while minimizing the other effects mediated by different alpha subunits.
Meaning less of the unwanted stuff.
Generally, yes. At typical hypnotic doses, they have minimal anticonvulsant or muscle-relaxing properties, which are linked more to alpha-2 and other subunits, and perhaps most importantly for sleep quality.
They don't mess up the sleep stages as much.
Right. That's a critical advantage. They tend to preserve sleep architecture much better than BZDs, causing less suppression of REM and slow-wave sleep. They also tend to cause less tolerance with prolonged use and have a lower risk of rebound insomnia upon discontinuation compared to short-acting BZDs.
But they're still controlled substances, so there's still some risks.
Yes, they are still classified as Schedule 4 controlled substances. Dependence and abuse can occur, although the risk is generally considered lower than with BZDs.
Okay, let's look at the individual drugs because their half-lives really differentiate them. Zolpidem first.
Zolpidem is probably the most well-known. It has a rapid onset of action and a relatively short half-life, around 2 to 3 hours. This gives about a 5-hour hypnotic effect, good for helping people fall asleep and stay asleep for a decent portion of the night.
And it comes in different formulations.
Yes, there's an immediate release, an extended release CR version, designed to help with sleep maintenance, a sublingual tablet for faster absorption, and even a low-dose sublingual form specifically designed for middle-of-the-night awakenings.
What are the main side effects or concerns with zolpidem?
Headache, dizziness, residual daytime drowsiness can occur. Anterograde amnesia is possible. And importantly, there's a known risk, though rare, of complex sleep-related behaviors.
Things like sleepwalking.
Yes, sleepwalking, sleep driving, making phone calls, preparing and eating food, all while not fully awake and with no memory of it afterwards. This is a serious potential side effect that requires patient counseling.
Okay. Next is zaleplon, even shorter acting.
Zaleplon has the shortest half-life of the three, only about 1 hour. Ultra short.
What's the advantage of that?
Its incredibly rapid elimination means it has the fewest residual effects on psychomotor performance and cognitive function the next morning compared to virtually any other hypnotic agent.
So it's ideal for someone who just needs help falling asleep, but has to be sharp very early the next day. The 6 a.m. worker example in our notes.
Exactly. If sleep latency is the only problem, zaleplon lets them fall asleep quickly, but clears so fast there's minimal risk of next-day impairment. The downside is it might not be effective for maintaining sleep throughout the entire night due to that short duration.
Right. And the third one is azopiclone.
Azopiclone has a longer half-life, around 6 hours. This makes it more effective for sleep maintenance, helping people stay asleep through the night.
Can it be used longer term?
It has data supporting its efficacy for up to 6 months of use in chronic insomnia, which is longer than typically recommended for BZDs or even zolpidem. The main adverse effects are residual somnolence, daytime drowsiness due to the longer half-life, and a significant number of patients report an unpleasant, bitter, or metallic taste in their mouth. Like the others, it's metabolized by the CYP450 system, so drug interactions are possible. ##tag B, targeting circadian rhythms, melatonin and orexin.
Okay, so Z drugs fine-tuned the GABA approach. But the next logical step was to move away from the GABA system entirely and target the body's own natural sleep-wake regulators.
Like melatonin?
Exactly.
Yeah.
Melatonin is the hormone produced by the pineal gland that helps regulate our circadian rhythm, our internal body clock. So pharmacologists developed melatonin receptor agonists.
Rameltian and tacimeltian.
Right. These drugs are selective agonists, meaning they stimulate the MT1 and MT2 melatonin receptor subtypes in the brain's suprachiasmatic nucleus, which is like the body's master clock.
So they're basically mimicking the natural signal for sleep onset.
Precisely. They help to synchronize the circadian rhythm and promote sleepiness, particularly helping with sleep latency difficulty falling asleep.
What's the big advantage here? Safety profile. Huge advantage in terms of safety and dependence. They have minimal potential for abuse or dependence. There's no significant withdrawal syndrome when stopped. This means they are not controlled substances and can potentially be administered long-term.
That's a major difference from BZDs and Z drugs. Any specific indications?
Rameltian is primarily indicated for difficulty falling asleep. Tasmeltian has a very specific indication, treating non-24-hour sleep-wake disorder.
What's that?
It's a circadian rhythm disorder common in people who are totally blind. Without light cues entering the eyes to synchronize their internal clock with the 24-hour day, their sleep-wake cycle tends to drift later and later each day. Tasmeltian helps to entrain their rhythm to a more normal schedule.
Any downsides or things to watch for with these melatonin agonists?
They are metabolized by the liver's CYP450 system, specifically CYP1A2 and CYP3A4. So co-administration with strong inhibitors or inducers of these enzymes can significantly alter drug levels, requiring caution. Rameltian has also been noted to potentially increase prolactin levels in some individuals.
Okay, so that's targeting the sleep signal. What about targeting the wake signal, the orexin system?
This is a fascinatingly different approach. Orexin, also called hypocretin, is a neuropeptide produced in the hypothalamus that strongly promotes wakefulness and alertness.
And loss of orexin neurons is linked to narcolepsy, right?
Exactly. People with narcolepsy type 1 typically have a profound loss of these orexin-producing neurons, leading to excessive daytime sleepiness and cataplexy. So the idea arose, what if we block the orexin system to promote sleep?
Which led to the orexin receptor antagonists, like suvorexant.
Correct. Suvorexant works by blocking the orexin receptors, OX1R and OX2R, thereby suppressing the natural wake drive produced by orexin. Instead of directly causing sedation like GABA agents, it allows sleep to emerge by reducing the wake-up signal.
What are the risks of essentially turning down the wakefulness signal?
The main adverse effect is, perhaps unsurprisingly, next-day somnolence or drowsiness if the effect lingers. More concerningly, there have been reports of increased suicidal ideation in clinical trials, requiring monitoring. And because it interferes with the wake system, it can sometimes cause effects that mimic narcolepsy symptoms, like sleep paralysis, hypnagogic hallucinations, or even mild cataplexy-like symptoms, transient muscle weakness. It's also metabolized by CYP3A4, so drug interactions are a concern. #C antihistamine-based options.
Finally, we should probably mention the agents that aren't primarily designed as hypnotics, but are often used for sleep simply because sedation is a major side effect.
Yeah.
The antihistamines.
Yes, the older first-generation antihistamines that readily cross the blood-brain barrier are quite sedating. Drugs like diphenhydramine, found in many OTC sleep aids like Benadryl or Nytol, hydroxyzine prescription, and doxylamine, Unisym.
Are they effective?
They can be effective for mild, occasional, or situational insomnia. Lots of people use them.
But they come with baggage.
Significant baggage, especially for older adults. They have potent anticholinergic effects, dry mouth, blurred vision, constipation, urinary retention, confusion. These side effects limit their utility and can be quite problematic, particularly in the elderly.
And some antidepressants are used off-label for sleep too, leveraging similar properties.
Exactly. Low-dose doxepin, which is actually an older tricyclic antidepressant with SNRI actions, is FDA approved at very low doses, like 3 to 6 milligrams, specifically for insomnia, primarily targeting histamine H1 receptors at those low doses.
And others used off-label.
Yes, trazodone and mirtazapine are very commonly used off-label for insomnia. Both are antidepressants with strong antihistaminic properties at lower doses, which accounts for their significant sedative effects. They offer an option for inducing sleep without involving the GABA system or carrying the dependence risks of BZDs or Z drugs, though they have their own potential side effect profiles to consider.
Okay, wow. We have covered a massive amount of ground here. From the mechanisms of GABA modulation through subunit specificity, pharmacokinetics, dependence risks, all the way to targeting melatonin and orexin. So, for the learner aiming for mastery, what's the synthesis? How do we boil this down to practical takeaways in a clinical scenario?
I think the absolute key, as highlighted in Figure 9.11 in our material, is understanding the trade-offs. There's no single perfect drug. Every choice involves balancing efficacy for the specific problem against the risks and side effect profile for that individual patient.
Right. Give us an example of a trade-off.
Okay, BZDs. They offer rapid, potent relief for acute anxiety or panic, plus useful anticonvulsant and muscle relaxant effects. That's the upside. The downside: high dependence risk, cognitive impairment, significant withdrawal potential, especially with short-acting agents, and dangerous interactions with other depressants.
Contrast that with buspirone.
Buspirone: slow onset, only works for GAD, no acute relief, no muscle relaxation or anticonvulsant action. That's the downside. The upside: minimal sedation, no dependence risk, no potentiation alcohol. Completely different profile, suited for a different patient and situation.
So let's try a quick clinical decision guide based on what we've discussed. If a patient presents in the ER with severe alcohol withdrawal or acute status epilepticus needing immediate stabilization,
The choice has to be an IV BZD, like lorazepam or diazepam. Fast onset, potent GABAergic effect, cross-tolerance with alcohol. Nothing else works as quickly or reliably in those acute settings.
okay, patient needs help falling asleep tonight, but has a critical presentation at 7 a.m. tomorrow and cannot have any hangover or grogginess.
That screams zaleplon. Ultra-short half-life provides rapid sleep onset with the lowest risk of next-day impairment.
Patient has chronic GAD and also struggles with insomnia, but has a significant history of substance abuse, maybe opioids or alcohol. Minimizing addiction risk is paramount.
That's a tougher one. You'd strongly favor non-controlled substances. Perhaps initiating an SSRI or SNRI for the GAD may be combined initially with low-dose doxepin or possibly trazodone at bedtime to address the insomnia, leveraging their antihistaminic sedation without significant abuse potential. Buspirone could also be an option for the GAD, maybe combined with a non-GABA hypnotic.
And one more. An elderly patient with mild difficulty falling asleep, but is extremely worried about memory side effects and falls.
There, you'd likely lean towards ramelteon, the melatonin agonist. It works with the natural circadian rhythm, has a good safety profile in the elderly, minimal cognitive effects, low fall risk, and no dependence issues. It directly addresses the primary concern about memory. So you see, the overarching concept, the real measure of mastery here, is deeply understanding that the clinical effects, both good and bad, are directly tied to the underlying molecular mechanism.
Frequency versus duration of chloride channel opening.
Right. That explains the safety difference between BZDs and barbiturates.
Alpha-1 versus alpha-2 subunit selectivity.
Explains why Z drugs are cleaner hypnotics than broad-spectrum BZDs, and why buspirone feels different. Understanding the target GABA, serotonin, melatonin, orexin dictates the drug's entire profile.
Which brings us to a final, maybe provocative thought for our listeners. We spent a lot of time differentiating the roles of the GABA receptor subunits, especially alpha-1 being linked to sedation, hypnosis, amnesia, and dependence, while alpha-2 seems more related to anxiolysis and muscle relaxation. So the forward-looking question becomes, building on this detailed knowledge, how might future pharmacologists really design the next generation of anxiolytics? Could they create molecules that are highly selective agonists or positive modulators for only the alpha-2 and maybe alpha-3 or alpha-5 subunit?
A drug that delivers potent anxiety relief.
Exactly, maybe even muscle relaxation if needed, but completely bypasses the alpha-1 subunit, thereby eliminating or at least drastically reducing the sedation, the amnesia, and critically, the dependence and abuse liability that plagues current BZDs.
That pursuit of ultimate selectivity based on this deep mechanistic understanding, that's precisely where the cutting edge of research lies. The search for targeted, cleaner relief driven by these molecular distinctions absolutely continue.
The comprehensive deep dive. Thank you so much for navigating us through all this incredibly complex but vital pharmacology.